Good morning, everybody. Welcome to the RCN webinar. We're just going to wait one more minute and we're going to get started as people trickle in. Okay, I think we're ready to start. Kyle, if you want to kick us off.
Yeah, so welcome everybody to the first event of our renewed RCN on wastewater-based epidemiology. We're really excited to have continued support for the next several years to continue these virtual activities with an expanded scope beyond SARS-CoV-2 to consider other pathogens as well. And Ali was telling me we have something like 170 folks registered for today. And so I think, it really emphasizes that the interest in this area is still really strong. So if you're not signed up on our listserv as we continue to expand and ramp up these activities and update our website, the best way to keep in touch with everything we're doing is through our listserv. I'm putting a link in the chat here, and I'll do it at the end of the talk too. So all you do is click on that link and click ask to join a group, and you should be kept updated on everything we're doing. And so with that, I'll hand it off to Ali.
Hi, everybody. Okay, we're just going to jump in and get started. We're really excited to have two great talks today. And I also wanted to highlight on this slide, you can see we also have two great talks scheduled for next time, which we'll send emails about. So today we have Robert Delatolla from University of Ottawa and also Marlene Wolfe from Emory. And Robert's going to kick us off with a 20-minute talk followed by 10 minutes of Q&A. Please put questions into the Q&A, not into the chat. And if you see a question you like that you'd really like answered, please upvote it by giving it the thumbs up on the Q&A. So with that, we're going to just jump right in, and Robert, go ahead and share your screen.
Thanks so much, Ali. Can you guys see the screen okay? Yeah, awesome. Well, thanks, Ali. Thanks, Kyle. Thanks, everybody, RCN, for having us here today to talk a little bit about flu surveillance, what we're doing in Canada and in Ottawa. So this project is really a project that was initiated, that was done through the University of Ottawa and in collaboration with CHEO, the Children's Hospital of Eastern Ontario, also partnering with the City of Ottawa, with Ottawa Public Health, and funded by the province. And with that, I'd just like to acknowledge that the University of Ottawa, CHEO, and the City of Ottawa are all on the unceded territory of the Anishinaabe Algonquin people. So very excited to talk a little bit about what we've been doing with flu surveillance. And so to start, a little bit of background information. So how we started to look at flu in wastewater was really through under the SARS-CoV-2 wastewater surveillance that's been happening here in Ottawa and in Ontario. What you see on your screen is a timeline of basically how that took off here in the province. The green being the timestamps of what was happening in the City of Ottawa, and then the blue being, the onset of a provincial program. And we have a provincial program here in the province of Ontario. And you could see the top right of your screen is a graph of the province. And just a little bit of background for you guys. We have 175 sites. They range from airports to long-term care, shelters, neighborhoods, and citywide level across the province. We end up covering with that program, and it's called the Wastewater Surveillance Initiative Program in Ontario. And we end up covering over 75% of the population of the province. So that's been happening since January 2021. And this work was all under that program. So how did we start doing flu when it was really focused around SARS-CoV-2? About this time last year, we went about, and we being the University of Ottawa with CHEO, And, you know, we start to survey our partners who are working on SARS-CoV-2. So we went to the Public Health Agency of Canada, we went to the Public Health Ontario, localized public health units, and we started to talk to our First Nation medical teams. And we started to ask them in this ad hoc survey in terms of what they thought was important going forward for wastewater surveillance. And influenza was the priority for all of them. And it's not surprising, there's an estimated worldwide death of about 300 to 600,000 deaths. In Canada, deaths due to flu are about 3,500 a year. And just to put that into context, Canada's about 10% of the population that the US is at this time. So with all of that, we started to do influenza testing in February of 2022. So just earlier, end of winter for us, early spring here in 2022 in the city of Ottawa. And we started to do that. And just as we were doing that, we were really thrilled to see this work come out from Marlene. So, you know, Marlene, Ali, and Krista and their teams and this really leading and sentinel work on flu. And that really gave us a lot of support and a lot of confidence, because at that time we're just getting flatline non-detects, which was kind of expected, but you never know if that's a good thing when you're starting a new program. So with that, you know, a couple of weeks later, we ended up actually getting hits in terms of getting some hot samples in terms of flu surveillance in our wastewater samples here in the city of Ottawa. And the first thing we did was, as we were testing, and by we I meant Shan, Liz, and the lab, what we ended up doing was we said, okay, let's do some fractionation experimentation. So we wanted to really understand where that flu virus target was really partitioned within the wastewater. So in the city of Ottawa, we have two types of wastewaters that we were working with. Primary sludge, which we collected at the wastewater treatment plant. That we have one central plant within the city of Ottawa. That plant in Ottawa is 1 million people, and 920,000 of those people all are sewered and connected to that one central plant, and that's where we collected primary sludge. We also collected wastewaters from 3 neighborhoods within the city. So that's our municipal wastewater. So what we did is fractionated the primary sludge into 3 basic fractions: solids. We did a PEG precipitation to look at colloidal matter, and then supernatant. And we did a similar fractionation with the municipal wastewater. Municipal wastewater was able to be filtered, so we simply did supernatant, filtered solids, and centrifuge solids. And when we look at those results, here are the results of the partitioning study on influenza A. That's what we had at that time. Was we had influenza A circulating within the community. We had an outbreak. So all of these samples are with IAV. And what you see in primary sludge is that we saw that almost all of the target was really partitioned to the solids in primary sludge. We weren't able to distinguish colloidal partitioning through PEG. Not to say it's not there, just we weren't able to distinguish it with that method. Municipal wastewater wise, same thing, really partitioned to the solids, whether it be the filtered solids or the centrifuge solids. We saw that that's where this IAV RNA was. And so that gave us a really good understanding of how to go about measuring it within our wastewaters. So based on the findings, this is the methodology and the analytical methods that we put forth. And, you know, finding flu virus partition to be very similar to the COVID-2, we basically used the workflow that we already had in place for SARS-CoV-2 in terms of analyzing and doing wastewater surveillance. And it's a really simple protocol. I think it's common to what some labs are doing. It's really an enrichment step of centrifugation. We do 2 things that might be a little bit unique. You know, it's a PCR-based method. The 2 steps that might be most interesting that we do is we have a step by which, once we centrifuge, we isolate exactly 250 milligrams of wet pellet weight. So we do that because we really focus, like we saw the partitioning for flu, partitioning for COVID-2 was similar, but the partitioning, it points us in the direction of solids. So what we end up doing is we go towards the solids mass, and we isolate the same amount of solids, whether we take 8 liters of wastewater or 500 milliliters of wastewater, we always isolate 250 milligrams of solids. That allows us to have a metric that's independent of flow. We know there's diurnal effects, flow varies day to day. We also know that flow varies from one day compared to the other. We have combined sources. There could be a lot of dilution or concentration effects due to flow. This allows us to to mitigate that and really focus as a mass fraction when we're doing our analysis. And then we normalize for PMMOV, which may be a little bit contentious, but we do that, but we do it a little bit differently, maybe. Because we've already isolated for flow, we were basically a mass-based method. The PMMOV is not acting as a surrogate to normalize for flow. It's acting as a surrogate. It's acting to tell us within that set defined concentration of mass, what is the proportionality that's fecal content? Because it's not all fecal content. There's inert substances there, there's fixed substances there. So that's how our method works. So we normalize for PMMOV after there's an internal normalization for mass within our protocol. And this is a little bit of how our workflow looks like. Probably conventional or similar to other workflows. We've been doing wastewater surveillance for a while now, and we're doing it through a contract. So we've almost become, this might look a little bit like a commercial lab, and sometimes I feel like we're feeling like a commercial lab when we're doing this work. And I'm just going to point a few things here. We have a Q analyzer step, so this is all automated. So we have some QA/QC thresholds that we have when we do the flu analysis. Also, when we do COVID-2, our method has an 8-hour turnaround time, and then we just basically push it through, and it disseminates the information to the program. All of our data is available on GitHub, so open science, everybody could get and see things that we missed in it, and it goes directly to public health. So that's how our workflow looks for flu. Now moving on to the data part, and what are we actually seeing, and what did we see? So this is the data at the city-wide level. So really busy slide, my apologies for that, but here's our information of what we saw earlier this spring in terms of flu. X-axis of the graph on the left is really time. You have two y-axis, left-hand side y-axis. One of them is for influenza A, that's in blue. The other is COVID-2 in orange. There's a right-hand side a y-axis. That's your clinical testing, your percent positivity. So the blue data points are actually the wastewater metrics. The blue solid line is the wastewater rolling average for those data points, and the dashed line is the clinical metrics for flu. Same thing for COVID-2, except at this point, everything is orange. So all the orange data is COVID-2. So again, the dashed line is clinical, and the solid line is the wastewater data. A few things to note from this slide. First of all, we had interesting occurrence in March in Ottawa. So we had all of our spring breaks, and right after our spring breaks on March 20th, the masking mandate got removed. When that masking mandate got removed, we saw these twin kind of outbreaks occur, flu and COVID-2 at the same time, and that's what you're seeing on the screen. I'm not sure if you guys can see my mouse, but it's right about that point right there with that dashed line showing us when the masking mandate was removed. A few interesting things. You see flu and COVID-2 both start increasing at the same time, probably because of that masking mandate being released, or because of that masking mandate being released. So a communal kind of initiation of those outbreaks. But then the slopes are different. You have a shallower slope for influenza. You have a higher slope for COVID-2. The peaking, because of those slopes, the peaking dates are different. But what's interesting is the resolution time, the resolution slopes seem to be similar, and they sort of resolve those two outbreaks at about the same point. One other key point to note is that the influenza is on an axis that's 2 orders of magnitude lower than flu. So we saw 2 orders of magnitude less influenza in our wastewater compared to COVID-2. And you can have different slopes, different kind of peaking dates. That could all be related to transmission, susceptibility of your population base. But there can also be other reasons for that in terms of, degradation rates and sores. It could be related to other kind of different components in terms of what's happening with the targets from a wastewater perspective. But what's really interesting is we saw a 2-order magnitude difference between COVID-2 and flu. We saw that same 2-order magnitude difference, and it's hard to see here because it's percent positivity in terms of the clinical metrics. So the clinical positive tests, even though they had completely different eligibility for flu and COVID-2 in the city at that time, showed 2 orders of magnitude differences between those metrics as well. And we thought that was very interesting, which to us implies that perhaps the degradation and the distinction, the shedding rate distinctions between COVID-2 and flu may not be that distinct, because we're seeing relational magnitude changes that are very similar to the clinical data. And finally, there's a little table on the right, and that shows us the early detection. So we were able to see really early detection between 2 and 3 weeks, and that's quite a long time. That early detection in the wastewater compared to clinical testing, really in the case of Ottawa and Ontario, is just a function more or less of how the clinical testing is done here. In order to be clinically tested for flu, you have to be a pediatric patient that's been at the ER, or you have to be a hospitalized patient, or it has to be a testing that's done if there's an institutional outbreak like at a long-term care facility. So when you understand how the clinical testing is actually performed in the city, then that 2 to 3 week lead time sort of makes a lot of sense with these two data sets. So that's what we were seeing at the citywide net level. Now moving forward to the neighborhood level. So we tested flu in the wastewaters in 3 neighborhoods, and you see those some characteristics of those 3 neighborhoods right here on the screen. And neighborhood 1 was a little bit distinct from the mean average of the city in terms of it had a lower mean age, so probably more children living in that neighborhood. Neighborhood 2, the characteristics and demographics were very similar to Ottawa as a whole, the whole city. Neighborhood 3, mean age was very similar, but there was a lot more congregate living. So the number of people per household was a lot higher. So neighborhood 1, younger, more children. Neighborhood 2, very representative of the city. Neighborhood 3, higher congregate living compared to the city. So let's look a little bit what we saw at the neighborhood level. So this is neighborhood 1, 2 graphs. Upper graph is flu, lower graph is COVID. The bars in the graph are your actual readings at the neighborhood levels. The line, the solid line, is the wastewater at the city level, and the dashed line is the clinical metrics at the city level. So the solid line and the dashed line are the same data you saw on the slide before. Now we're looking at how the bars compare to those data sets. And here, the first thing we see when we're looking at flu in this neighborhood, again, this is the neighborhood with younger, with a lower mean age and more children in the neighborhood, we see this event of early peaking. So you see that one bar around April 5th, this really, really big bar of flu at that time. So we see an event of early peaking within this actual cohort of the population. And that's largely probably due to early transmission because of the younger children living in the neighborhood within that community. So if we move over to the neighborhood number 2, this is the neighborhood that really represented and had the same characteristics and demographics that we saw at the citywide level in Ottawa. And if, again, the top graph is flu, the bottom graph is SARS-CoV-2. And what you see when you look at the data here is you're really seeing a good kind of representation of the bars lining up with that solid line, meaning it's sort of representative. The readings at this neighborhood are sort of representative of what you're seeing citywide. And that to us made a lot of sense when you look at the demographics and characteristics of this neighborhood. So neighborhoods that had similar demographics, that had similar characteristics to the city as a whole, showed similar trends and patterns within our wastewater surveillance as we saw at the citywide level. I mean, there's always some outliers. If you look at the COVID-2, you could see here that you have this sort of outbreak and this higher signal towards the end as those waves were coming down. But for the most part, we saw this interesting similar trend and sort of similar peak times with the flu and with COVID-2 within this neighborhood compared to the city. And moving on to the third neighborhood. So the third neighborhood, the characteristics were a little distinct compared to the city with respect to the number of people living per household. So there's more congregate living in this neighborhood in Ottawa. And we see some distinctions here. The first thing to say about these graphs, again, flu is on top in blue, COVID-2 is in orange right underneath. The first thing to say is that the y-axis on the left-hand side is actually higher than the 2 previous graphs you've seen, the 2 other neighborhoods. And that's because here in this actual cohort, this community, this neighborhood, we saw the highest measurable flu values we've seen throughout the entire project. And what's interesting here is we see the highest possible values, but we see those values come at times that are sort of consistent with the wave. They're not peaking earlier than what we're seeing within the wave within the city. They're peaking at about the same consistency and the same pattern of timing as the wave is peaking in the city. The only thing is they're peaking at really, really high levels. And again, considering that there's a higher number of people per household, more congregate living, higher density living in this community, you know, there's a higher possibility of transmission here. So this might be one of the reasons. So we are, you know, this might be one of the reasons that we're able to kind of see this higher amount of concentration within the wastewaters because of that congregate living situation. Again, these are all hypotheses. These are all possibilities. We're hoping to see, we're very interested to see what we're going to get this round through this flu season that's coming up. But these are some of the takeaways from the information that we saw during that unprecedented spring twin outbreaks of COVID-2 and flu that we observed in Ottawa. So one other piece of information that we're able to get out of this study was subtyping. So subtyping, whether that's valuable or not, is really going to, I guess, depend on what's happening clinically within your region. For us, subtyping was not very common and did not occur across all demographics in the province. So we were able to subtype quickly. It's just an additional PCR test in terms of what a subtype of influenza A were we actually seeing during this outbreak in Ottawa. And it showed to us that it was H3N2. So this was an outbreak of H3N2. We actually Sanger sequenced it, the amplicon of our PCR test, just to kind of ensure that this is really what we were seeing. And all 15 tests that we performed, we did about one a week at the citywide level and at the neighborhood level. They confirmed that it was H3N2 in the city. So where are we now? What are we doing? So moving forward for this flu season and this winter and fall season here in Ottawa and Ontario, we're looking at continuing the flu monitoring. We're actually added RSV also in addition to COVID-2, and we're looking at monkeypox and really looking forward to Marlene's talk on monkeypox right after this. And there's going to be a dashboard now. So the Ottawa Public Health has been really supportive of this work, and they're going to put up a dashboard that's going to kind of be presenting this information directly to the public on a respiratory dashboard, the clinical data with the wastewater data just this fall and winter season. They also have translated this information that they're looking, if we see the same lead times, that they will, you know, they will communicate. This will give them the ability potentially to communicate to healthcare partners, to inform testing decision, antiviral decision, and staffing decisions within their public health unit in the city. And with all of that, yeah, that's basically the summary of everything that we've been doing with respect to flu and wastewater and what we plan to do. And by we, I really mean these people. These are all the great people from our labs, from the CHIO lab, from the U Ottawa lab, who are doing all the work. Liz is the one who wrote the paper. Shen really guided that work. Everybody here had a hand in all of this. We really thank them. We thank our partners, City of Ottawa, Ottawa Public Health, Province of Ontario. And thanks to you guys for listening. Really appreciate it.
Thank you, Robert. That was a great talk, and I'm sure I'm speaking on behalf of the entire audience. Thank you for such a clear and really exciting talk. We have some questions in the chat, so I'm going to moderate those. And if you have other questions, please go ahead and throw them in there and upvote questions that are already in there that you're interested in. Okay, so I'm just going to jump in here. So one question that comes from Chuck Haas, if you don't mind, Chuck, me mentioning that it's from you. Can the greater offset between the wastewater and clinical cases be explained by what might be known about the incubation time of influenza? So the shift of that clinical case peak.
Yeah, so yeah, Chuck, that's exactly right. And I wanted to convey that, and I probably didn't mention it. So thank you for mentioning it. You're exactly right. There's a lot of hypotheses in terms of that offset. So, you know, right now that's something we wish to dig further into. This was the first kind of, you know, real wave that we were able to catch. So we really didn't know what to see, but that was really interesting that we saw those offset times. So absolutely incubation period, a lot of different parameters that could be affecting that distinction. And hopefully we're, you know, as we keep doing this and as others keep doing this and Ali and other teams keep doing this, hopefully we can elucidate what are the reasons for those offsets.
Okay, great. Okay, so and the next question, Devram Kaya asked this one and it got a couple upvotes. What percent of population has pepper in their diet? I'm wondering what percent of population is not covered by PMMOV and wondering if something else could be used as a human fecal biomarker.
Yeah, that's another really good question. I mean, the percentage of people that have pepper in their diet is really, I don't know the answer to that, but I know we have a PhD student in our group, Pat, who's really looking into that. And I'll tell you that we use pepper at this point as a normalizing parameter, especially at the citywide level, because it allows us to get higher correlations, you know, time step modified correlations to clinical metrics here in Ottawa and a few other sites. But what's interesting is the diet definitely affects it. Like when we were at a long-term care facility, we actually had to get sent the menu of the long-term care facility because they actually had like pepper pizza, then they had like pepper stir fry, and like our pepper values went through the roof. And it really was diet dependent because it's like a few hundred people. So you got to ask yourself, well, at that level, does it make sense? And maybe not. But at the citywide level, we sort of lean on it at this point because it gives us better correlations. But absolutely more work is needed to kind of to understand if that's the best way to do it and what's better. Yeah.
Great. Okay, we have a question from Amy Pruden. Interesting that you hypothesized that shedding would be similar of SARS-CoV-2 and influenza. I would think influenza would be more localized to respiratory secretions and then incidentally swallowed than COVID, which appears more systemic.
Yeah, that's a good question, and I probably shouldn't have hypothesized that they were shed the same way. So what I find interesting within the data set is that you know, you're looking at two different data sets clinically. You're looking at a data set with a completely different eligibility for testing for flu in this cohort of people compared to COVID, like completely different eligibilities for testing. And when you look at those two data sets and you look at the two waves that happen, one at the same time as the other, the magnitudes were really off by 2 orders of magnitude, by about 100. It was like, I think we peaked at like 386 COVID positive tests in the city. Again, that's a very small cohort being tested. And we peaked at about 4 flus per day at the city. So it was really that 2 orders of magnitude difference in clinical data was represented again within the wastewater. And I think that because you could see that ratio between the wastewater targets and you see the same ratio in the clinical metrics targets, I find it quite interesting. And we're starting to see this again when you bring a third target in of RSV. And I don't know if this is something, maybe it's nothing. It requires definitely more eyes on it. But I think at this point, you know, there's a lot of concern about the impact of fecal shedding on monitoring and how do we then mitigate that impact when we try to relate it back to clinical tests. And there's a lot of concern about degradation within pipes. And these are all great questions. When we see similar ratios between those parameters, I think it's a little bit of a positive note in terms of potentially the wastewater surveillance, at least when you have partitioning. And I don't think this is independent of the fact that all these disease targets happen to partition in the same way. So because we see that partitioning being very similar, I wonder if this is an indicator and telling us that maybe there's some extrapolation that can be done with some confidence back to clinical metrics if we are seeing similar ratios. I don't think I answered that very well, Ali. I probably sidestepped it, but
no, I think you did a fine job. We're going to ask one more question. There's a couple questions related to the partitioning to solids. And so we'll have time for just one simple one, which is, do you find also more SARS-CoV-2 in solids or only influenza?
No, we definitely find both. Yeah. When we partition CoV-2, we definitely find it in the solids, and we've been looking in the solids the whole time. And we're hoping to do some interesting analysis, like we mentioned about the entire program in Ontario, where we did a whole bunch of different methods in the program, and that's kind of precarious at times, but can be beneficial. So we're really excited to look at all the various methods that we did, some of them looking in the supernatant and liquid, others looking in the solids. And we're trying to figure out a way to wrap our head around how to evaluate that and see if we could come out with some conclusions based on the work that we did here in Ontario, and if that supports the partitioning that we've seen of COVID-2 to solids. Thanks.
Thank you so much, Robert, for the great talk and Q&A. And if you guys have more questions for him, I'm sure he would be happy to receive emails about his work. Okay, so we're going to transition now to Marlene Wolfe at Emory. And Marlene, you can go ahead and share your slides.
Okay, let me pull them up. Okay, can you all see what I'm seeing?
Yes.
Thumbs up. Okay, great. Thank you. Yeah, thank you so much for having me and for having the amazing planning to put these two sessions together, because Robert has just given us a lot of the background that I might have discussed about solids. So that is fantastic, because our program also utilizes wastewater solids. So I'm going to be talking today about expanding a wastewater monitoring program for new targets, and specifically focused on the addition of MPOX to a routine program. This is our full list of authors on this preprint that we've released, and we have, many other people who make this program go. Okay, so like I mentioned, we do our wastewater monitoring programs using solids. So wastewater, of course, includes both liquids and solids. We use the solids because, as we just saw very well described in the last presentation, viruses are often naturally concentrated in the solids. And this is something that we've seen since the beginning when we started working on this topic of wastewater monitoring for SARS-CoV-2 in March of 2020. One of the first things we did was to look at which fraction of wastewater would yield better results. And for us, what we found pretty early on is that we had really good sensitivity from using the solids. These are a couple of our papers that were kind of originally looking at using settled solids, and then also even at that early stage in 2020, looking at a bunch of sites around the country and seeing that we had sort of similarly consistent and good results for SARS-CoV-2 using solids. Something I want to emphasize about the solids is that, a lot of our work we've done is collecting settled solids directly from a primary clarifier. And if a plant has a primary clarifier, there are a lot of advantages to that, because it's already a sort of naturally composited and naturally solids enriched sample. But we also have done a lot of work utilizing the solids from a sample that's taken of, quote, liquid wastewater, because the wastewater coming into a plant or within the system has solids suspended in it. And so we will settle out, and you see this picture, this series of pictures here over the course of 15 minutes, how solids are settling out of that influent wastewater sample into kind of a thickened portion that you can use. So once we had seen that we were getting really good and sensitive results from solids, we started a more high throughput wastewater monitoring program. And this is background. I promise I'm going to get into MPOX soon. But about 2 years ago now, we started this program called the Sewer Coronavirus Alert Network, or SCAN. And over time, we have done between 8 and 12 plants in Northern California. And the goal was to take those methods that we'd been working on and saying, like, how useful can this really be to public health if we make this sort of as high throughput and rapid as we possibly can. So we started taking daily samples of solids from these plants and had a 24-hour turnaround on the results. And we quickly expanded from just SARS-CoV-2 into also variants, and then into other viruses. So, at this point, within that original SCAN program, we're monitoring for SARS-CoV-2, variants, influenza A, RSV, and human metapneumovirus, and then also MPOX. This is the QR code there takes you to our research dashboard, which has all of that data for the past 2 years. And this is kind of the progression of how we got to the point of being able to roll out kind of MPOX testing in many places around the country. This program has been fantastic. It's been an amazing opportunity for us to try out new things, build really close partnerships with public health, provide data that is sort of immediately available and useful. And so we then had the opportunity to scale that up further to expand nationwide. So wastewater SCAN, the C is no longer coronavirus, because we're doing a bunch of other things, is now a nationwide expansion of that's based on this program. And so we're enrolling 300 plants nationwide for a network of sites that, using the same methods and the same process within the same system, we can provide information on infectious disease trends across the country. This is intended to be complementary and working with all of the programs that have dug in really deep in different places. So we, want to be working with and complementary to state programs, for example. And our website's there if you want to find out more. So our analytical process for both of these programs, both of which we have MPOX data from right now, is using the solids. So the pre-analytical methods are that we do centrifuge down the solids so that we get a precise measurement. We take, the exact same mass of solids then from each sample. We resuspend that in a buffer solution and bead the heck out of it. And then we spin that back down and we use the supernatant of that buffer to then go directly into a nucleic acid extraction step. We use the Chemagic 360. This is an extraction method that yields both DNA and RNA. And then after extraction, we do an inhibitor removal step just to, help make the sample a little bit cleaner for the PCR. And then finally, we use droplet digital PCR. We're using the Bio-Rad system, and we multiplex targets and controls. And so the thing that has been really amazing about this process, as many of us in this field have experienced, right, is that we can use this same analytical workflow to then swap out new targets just by changing what's going on in the digital PCR step. And so that is, how we're able to add things like MPOX. So adding new targets, our process to adding new targets began with SARS-CoV-2 variants. And so we have had a consistent workflow that we use to hit the same points each time to make sure that we're ready to deploy a new assay, whether it is for a new variant of SARS-CoV-2 or an entirely new virus. So the first is that we are identifying an emerging pathogen or variant. It's identified, it's sequenced, and we're able to identify conserved regions that will be good targets for monitoring. Then, if it's something new, like a brand new variant, we would design primers and probes. Sometimes for, existing diseases, it's a good idea for us to design a new assay. We check for specificity, but also if there are assays that are available in the literature, we'll use those. Then as quickly as possible, we'll procure the primers and probes. And I think many of you probably know that this is probably the biggest challenge in the process at times, getting these materials, the primers and probes that we need, and positive control material, whether that's a synthetic control or a sample that can serve as a control. We then test the assay specificity and sensitivity. And then once we are convinced that that assay is specific and sensitive, working well in our process, then we apply that completed assay to a test set of samples before we are able then to deploy it as part of our regular monitoring program. Like I said, the program targets that we've been working with recently are SARS-CoV-2. We have 2 targets we're doing for SARS-CoV-2. We're doing a mutation that's in BA4 and 5 right now, influenza and RSV. We also run pepper mild model virus as an endogenous control. And again, I'm not going to repeat the description of sort of how we think about that for solids, because Rob gave us a really great in-depth description, and we think of the same way as a control for fecal strength of the sample. And then also bovine coronavirus. And then what we have now is the addition of MPOX. So MPOX is a double-stranded DNA virus. It's the first DNA virus that we have done as part of our program. Clinically similar to smallpox, but less transmissible and severe. Presents with fever, rash, swollen lymph nodes, lesions, can lead to a range of complications, right? So we're all relatively familiar with the idea of MPOX now after the past couple of months here in the US. And the 2022 outbreak, right, is different because it really seems to be driven by human-to-human transmission. MPOX is usually a zoonosis, and outbreaks among human populations have been relatively self-limited. So that was something that was quite different and a little bit scary at the beginning of this outbreak, that there seemed to be widespread transmission and possibly even a number of asymptomatic cases that were not being identified. So we immediately went and, the first step before any of the technical process is to say, does this make sense? Is this a good idea for us to monitor as part of a wastewater program? Is this target likely to be in the wastewater? Because if it's not, then there's no point in monitoring it through the wastewater, right? But there were a number of studies, not very many, but a few that confirmed the presence of viral DNA for some individuals, saliva, feces, urine, semen, and or skin lesions. Kyle Bibby actually has a paper that recently came out talking about kind of the idea of MPOX monitoring and thinking about these different inputs that are going into wastewater. So that was unfortunately not out at the time that we were making this decision, but there is more and more good evidence showing that, like, yes, this is, going to be consistently shed into wastewater. So here's how the process went for us adding MPOX specifically, first to the scan sites in our two programs. So we noted the outbreak, we noted that this was likely to end up in wastewater. So we were like, great, I think this is worth trying. And we identified a couple assays that were existing that were good matches for the sequences that we were seeing so far from the outbreak. So the G2RG and then G2RWA assays. G2RG is general and it detects both clades, and then G2RWA is specific to the clade causing this outbreak. So we confirmed that choice by alignment with sequences. We then very quickly ordered primers and probes and G-blocks as positive controls in May of 2022, and we were fortunate. Those arrived within 7 to 10 days. So we were able to get our materials pretty quickly to begin that specificity and sensitivity testing. We tested to confirm specificity and sensitivity and tested against some banked stored wastewater samples from early May. And then after confirming that, that it was working and knowing that we had started to see a couple cases in California, we began testing our original scan plants on June 19th. After doing that testing for a few weeks, we were then able to expand to plants nationwide in early July. We began testing on June 19th, and we had our first positive sample on June 20th, which was, I think, much faster than I at least expected to see a positive sample. So we were like, let's try this out. We've got buy-in from everybody. We talked to all of our public health colleagues in depth about this before beginning, and we were definitely surprised. And I think pleasantly surprised, I'll say, because we did know that there were some cases in the area at the time, that we were able to detect it in the wastewater pretty quickly. So one of the things that we did was comparing the matrix and targets. So comparing the solids and the liquid samples. We saw that the results agreed between these two assays that we were running, G2RG and G2RWA. And those are the pink and the green on this. And so you can see that there is a really good alignment in the results that we got from those two assays. And so that increased our confidence in saying, this is very specific to MPOX in addition to the kind of laboratory testing that we had done. And then we also did a comparison of testing of liquids and solids. So we used the series nanotrap particles to concentrate the liquids, and then our solids protocol. And what we saw was similar sensitivity actually between the two, but a much higher concentration of viral DNA in the wastewater solids. So you can see the triangle is solids, and then the circles are liquids. I know this is a pretty technical group, so I just wanted to put this slide in here to show you kind of what some of our quality control steps are, because I think it's particularly important for something that is new and emerging and, could potentially trigger cascading consequences like MPOX, that we're really clear about the quality control measures that we use to make sure that we're really positive that a detection is actually a true detection. So these are some of our quality control metrics that we use. And also we did a comparison because this was the first DNA virus that we had done. We did a comparison of our RT ddPCR master mix with a ddPCR master mix without the RT step. And we were able to confirm that the results were the same across those two. And so we're able to include MPOX in our workflow with RNA viruses and actually multiplex them together just using the RT ddPCR master mix. And then here are the results from the initial 9 communities that we are working in. So there are 9 sites in the Bay Area in Northern California that we first rolled this out to. And the first positives, like I said, we had on the second day of monitoring. And what we saw is this pattern of sporadic early detections. As you can see here, we didn't have positives every single day, but then that was followed in some of these places that are places that had higher numbers of MPOX cases ultimately by increasing rates of detection and concentration. So something, you know, what we like to do for a rare target like this, whether it's a new variant or something like MPOX, is to look at a heat map like this to say, you know, when do we start to see increasing rates of detection, then followed by increases in concentrations if an outbreak is continuing. These are the 4 sites that we had that had the highest concentrations and the most positive detections of MPOX during the time period. And so our kind of comparison of cases and wastewater data is focused on this. We had a great partnership with the California Department of Public Health to do an analysis of MPOX cases and these wastewater results. And what we found is that there's a strong association between MPOX DNA concentration in wastewater and cases. So you can see on the top here, these are the wastewater results in copies per gram. And then you can see on the bottom here, we have the incidence rate per 100,000 people in the exact sewer shed area matching the wastewater that was collected. And so the green here is the case data based on report date. So when that case became known to public health, and the red is episode date, which is typically the first symptoms experienced. And we saw a really a significant strong relationship between both of those ways of looking at cases and the MPOX data. We also detected the MPOX virus DNA at 5 of the 9 sites, either prior to or within a day of the first case being identified in the sewer shed. And so it appeared to be a very timely measurement of the presence of the disease in the community. And this just shows you the relationship here between, this is the MPOX virus DNA over PMMOV and the average daily incidence. And so we see this strong, significant relationship between the 2 measurements. So this, again, this is a preprint, it's on medRxiv. And so you can check out all the details of our methods and results of this analysis of comparison in that preprint. So as I mentioned, after we had done the analysis that was in this paper and had a lot of confidence to say that there was, our methods were working really well, that this was giving us information that was potentially useful for public health and likely associated with cases, we then were able to roll out this monitoring to the sites that are kind of currently and actively being enrolled in the wastewater scan program. We are, like I said, working up to 300 sites, and we are ramping up right now. So that number has been changing and growing over time. But at this point, within the wastewater scan network, we have had 55 of 72 sites that have had a sample positive for MPOX DNA in 15 of the 20 states that we're monitoring. You can see that we've got overall, again, this is a snapshot of sporadic parts of the country, right? That really high one that's kind of making it a little hard for you to see down here is actually right in my backyard in Georgia. But what we see overall is this is mirrored in kind of what the overall shape of the outbreak appears to be. This is the case data that's publicly available from CDC about 7-day average of new MPOX cases nationwide. Our highest concentrations observed were in the Bay Area and in the Atlanta metro area. I'm realizing that California got cut off of my legend. This darker blue color is California. So this is part of San Francisco right here. And then this is part of the metro Atlanta area. So that's where we've seen some of the highest concentrations throughout our monitoring, but concentrations are leveling out and now declining quite a bit in these areas with the highest concentrations and generally overall across the country, which is really good to see. just to drill down a little bit more, so this is the Southeast. This is HHS Region 4. Looking at the MPOX copies program again, so you see consistently kind of going down even at a regional scale. And then this is California. And so you can see again that for the most part, we have concentrations that are going down. This is for California. The California data is available on number of cases. So this is publicly available data from CDPH, 7-day average new cases over time. And you can see that there is a pretty good alignment between the wastewater data and that case data from across the whole state. So some successes and challenges. I think that, you know, for us, this has been an exciting success because I think we've been able to demonstrate that we can pretty rapidly validate an approach to a new target that's even an emerging, I mean, MPOX is not a new virus, right? It was newly emerging within the United States, emerging in that the patterns of transmission for the virus were changing, right? But we did have literature to fall back on because it's not a new virus. But I think, you know, being able to demonstrate the validation of an approach to an emerging disease and quickly deploy it within wastewater, we began daily monitoring within a month of the first case in the US, and then now have been able to expand that testing to 20 states. And so I'm very, very proud of the hard work that our team has put in to make this happen and make it happen rapidly. And to me, what is most exciting about this is the proof of concept to say, you know, the thing that we wish we had, which was the ability to do the amazing testing that so many groups are doing around the country and around the world for SARS-CoV-2, you know, that we wish we had been able to do that at the beginning of the pandemic. This increases my confidence that we really can respond quickly to new threats using wastewater monitoring. Challenges are, of course, supply chain is always a challenge for something new and is the main thing that I think slows us down in testing out and deploying something new. But also rapidly sharing guidance on interpretation and coordinating with CDC, state and local public health. Like I said, we are working now in 20 states, and we have had a really strong relationship with CDPH, who were partners on this preprint and who we've worked with for, you know, all of SCAN for 2 years. We also have good relationships with many departments of public health that are part of wastewater SCAN, but it requires, you know, each public health department has different needs and different concerns about receiving this type of data and a responsibility to explain it to their public. And so I think that, you know, ongoing challenge as we think about, you know, maybe there's another thing that needs to be monitored in the future is setting up that conversation to build the confidence and relationships to continue to be able to monitor things that are challenging and new and explain that to the public and work together in that process. This is my last thing. So future goals.
Marlene, I was just going to interrupt you.
I know, I'm almost done.
And I know you won't be mad, but I think you need to stop talking because there's so many questions.
Okay, so we also really care about endemic and seasonal diseases. And I just want to point out this preprint that Ali led on monitoring for a bunch of respiratory viruses. And so the dual use of a platform like this for things that are seasonal outbreaks and things that are emerging is the goal. Okay, I'm done. Thank you. All
right.
Is everyone.
Thank you so much, Marlene. I know I speak for everyone when I say it's super impressive, the agility and scale. So I'm going to try and get through as many of these questions as possible, but
I'll try to answer quickly.
You're going to be willing to answer offline as well. I'm going to volunteer you. All right, so the first question in the box from Chuck Haas again is, if there's a sense, how much of monkeypox shedding is coming from fecal excretion versus washing off of the skin of active or not yet diagnosed symptomatic cases?
Yeah, it's a really good question, and I don't think we have a very clear answer to it. And I think this is the ongoing challenge with all new targets that we're looking at, is I just would beg of everyone and anyone who has access to feces to do more testing on shedding, feces, urine, skin, everything, like to have more good data on the quantity of these pathogens that's being shed into wastewater, really improve our approach. And I don't think we have very good information on that. Kyle has done a little digging into into that in his paper. And so I think that's a good place to look for more info. But one of our approach, at least to thinking about what seems likely to show up in wastewater that we could monitor, is definitely not to limit that to urine and feces. You know, like every drain that goes in your house, every drain goes to the sewers, right? Well, okay, that's a broad generalization, but for the most part, right? If it's like a respiratory secretions, if it's on the skin, we do think that the lesions are contributing, but there are definitely urine and fecal secretions that I think are probably a very significant contributor to what we're seeing in wastewater.
Cool. Oh gosh, the upvoting's happening so rapidly. Okay, so this one is one I upvoted, so I'll selfishly start with that one, which is how did you involve the targeted populations when you chose to add the target of monkeypox? So you talked about engaging the public health representatives, but I guess how much citizen stakeholder buy-in did you get when targeting from targeting an aerosol base to a contact-based viral spread?
Yeah, so our focus is on in terms of that stakeholder buy-in and talking about new things that we're going to monitor in a community, is on conversations with public health stakeholders who are responsible to communicate back to the public and accountable to them, and to the wastewater treatment plant and utility workers who are providing the samples and who may have concerns also about, you know, what is present in the wastewater. And so that is where we focused. I will say, you know, we have had very in-depth conversations with CDPH, since that is where we began the initial work, which was very experimental, right? And then also conversations with our expanded wastewater scan network about these changes. Something that is a little bit challenging is we are actively recruiting communities into wastewater scan. Like it's open. We have 70-ish right now, right? And we're going up to 300. And so folks who are coming to us now, we're already measuring MPOX, haven't necessarily been a part of those conversations that we had to set up the idea of monitoring the first place and roll it out. So something that we're continually trying to reevaluate and work on is, what is our process for making sure that everyone is comfortable with receiving this data right away and knowing what to do with it? Because we've had plants who've joined, and, you know, the first sample that they get back from us has that data as part of the, you know, package that's included. And so I think, you know, in such a dynamic place right now, having those conversations with stakeholders and making sure we're all on the same page is especially challenging. I think it would be a little easier as it was with SCAN, where we had, you know, kind of a closed cohort of folks who were all really, you know, bought in right away. So I think it's something we're definitely thinking about, not just with MPOX, but for all things that might come in the future, is that increasing that coordination. It's challenging.
Cool. This is a conversation I had yesterday, which is you successfully multiplexed both DNA and RNA targets in an RT-PCR when you did a nucleic acid extraction. So Amy just wanted confirmation on that.
Yes, that's exactly right. And we tested both the extraction kit compared to a DNA only extraction kit, and then also the ddPCR with and without the RT step, and found that we got the same results when we multiplexed it in with other viruses with the RT step.
All right. And then Natalie has a question. Any plans to add a non-TNF target for monkeypox, given the CDC lab alert of detection failures in 3 California cases based on a deletion in the TNF region?
Yes. So we've been watching this really closely, and the conversation about this and alert about this has been going on for at least a few weeks now. It appears that it's a relatively small percentage of sequences that have this deletion, but of course that could be biased also. So it's something that we're continuing to look at. We are not immediately making a change to the assay that we're using, but we are probably chatting about it daily, honestly.
Yeah. Okay. What did you do to get such a quick turnaround time?
We've been doing it for 2 years. Honestly, I mean, we have this amazing team. We've built up these relationships. We are academics. Me and Allie are running this project, Wastewater Scan. We are academics with our own research labs, and we don't run these samples in our research labs. We work with Verily. They are an industrial lab. They are an amazing partner. And so we have been able to build this group that can offer this program by building that relationship over 2 years and working with an industrial lab and not just with our students. Our students are amazing and contribute to this work, but Verily runs samples in their lab.
Awesome. I think we might be out of time. I guess I want to squeeze. Okay, I'll let Allie decide. She just turned on her camera.
Go ahead. Go ahead.
Okay. Kyle, I do want to. Kyle had this question that I was also curious about, so I want to squeeze this one in, which is when you talked about your QA/QC for the monkeypox. He was wondering if you used similarly high numbers of pool replicates for other targets, or if that was mostly driven by your expected needed sensitivity for monkeypox.
No, so we do the same thing for everything. The reason there are 2 numbers on that slide is because we use 10 replicates for scan and we use 6 for wastewater scan. That's based on an awesome analysis that one of Allie's grad students did, looking at sort of what is our sweet spot for sensitivity. And we use that the same across all of our targets, and we've had pretty consistent results. It's worked well to use the same level across all the targets.
All right. Well, thank you so much.
Nels here. Thank you so much.
Thanks, everyone. Thanks for attending. This is recorded, so we'll be sending the link out, and please join us on November 4th as well for 2 additional great talks. Thank you. Thank you to our speakers. Have a great day.